One of the reasons why an FPD fails is not understanding the concepts of occlusion in fixed partial denture. I take up the duty to simplify and demystify the concepts and philosophies of occlusion in fixed partial denture. Let's understand what is occlusion. The static relationship between the incising or masticating surfaces of the maxillary or mandibular teeth or tooth analogues. It is the static contact relationship of maxillary and mandibular teeth in any given position. Articulation, the static and dynamic contact relationship between the occlusal surfaces of the teeth during function. Compared to occlusion, this is a contact relationship of maxillary and mandibular teeth in function. What is centric relation? The maxillomandibular relationship in which the condyles articulate with the thinnest avascular portion of their respective disc with the complex in the anterosuperior position against the slopes of the articular eminence. This position is independent of tooth contact. This position is clinically discernible when the mandible is directed superior and anteriorly. It is restricted to a purely rotatory movement about the transverse horizontal axis. Maximal intercuspal position. The complete intercuspation of the opposing teeth independent of condylar position, sometimes referred to as the best fit of the teeth, regardless of the condylar position. It is also called maximal intercuspation. What is centric occlusion? The occlusion of opposing teeth when the mandible is in centric relation. This may or may not coincide with the maximal intercuspal position. Even after knowing all these details, we fail to predict the success of an FPD or crown. To predict the success of an FPD or crown, we need to understand the biomechanics of stomatognathic system. So let's understand the biomechanics. To understand the biomechanics, we need to resolve mandibular moments and occlusal contacts. So basic moments of mandibular movements is divided into two basic components: rotation, translation. What is rotation? The action or process of rotating on or as if on an axis or center. What is translation? The motion of a body at any instant when all the points within the body are moving at the same velocity and in the same direction. This refers to a bodily movement. Coming to excursive movements. Opening movement. On opening, initially up to 20 mm of incisive separation, there is only rotation of the mandible, which is then followed by a forward translation of maximal opening. The rotation occurs around the horizontal axis and can be observed in the sagittal plane. Protrusion. This is a translatory movement as the mandible slides downward and forward for the anterior teeth to meet edge to edge. Protrusion. The movement is just opposite of protrusion. Lateral excursion. Movement produced when the mandible moves side to side, that is right and left. Rotation in vertical and sagittal axis during lateral movements on the working side with a little translation called the Bennett moment or mandibular side shift. So if the mandible is moving to the right side of the mandibular movement is called the working side, and the other side, the left side, is called as non-working side or is called as balancing side. Occlusal contact in laterotrusive mandibular movement. In the posterior teeth on the left side during a left lateral movement, which is called again as working side, contact can occur on two inclined areas, that is, between the inner inclines of maxillary buccal cusp and outer inclines of mandibular buccal cusp, between the outer inclines of maxillary lingual cusp and inner inclines of mandibular lingual cusp. Both these contacts are termed as laterotrusive or working contact. During lateral movement of mandible, if the contact is only in the palatal slopes of canine and rest of the dentition is disoccluded, it is termed as canine-gated occlusion. However, due to wearing off of the incisal edges of the canine, multiple posterior teeth may come in contact on the working side with the non-working side teeth in disocclusion. This is termed groove function occlusion. Coming to determinants of mandibular movement, we have posterior determinant and we have anterior determinant. Coming to posterior determinant, posterior determinants are inclination of articular eminence. Greater the angle of eminence, greater is the allowable cusp height and deeper is the fossa of the teeth. Intercondylar distance, this is the distance between the two rotational centers of the condyle. A larger than average distance requires more distal positioning of the oblique ridges and grooves on mandibular teeth and more mesial positioning on the maxillary teeth. Side shift. Greater the immediate side shift, shorter is the allowable cusp height. Greater the lateral protrusion, that is outward and upward movement of working condyle. Shallower the grooves and less the cusp height. Greater the lateral detrussion, that is outward and downward movement. Deeper the grooves and greater the cusp height and vice versa. Coming to anterior determinant, vertical overlap. Greater the vertical overlap of anterior teeth, greater is the allowable cusp height. Horizontal overlap, greater the horizontal overlap, shorter is the allowable cusp height. Occlusal plane. When the plane is more parallel to the condylar guidance, allowable posterior cusp height is shorter. Conversely, more convex the curve, allowable cusp height is lesser. Coming to concepts of occlusion, we have unilateral balanced occlusion, mutually protected occlusion, canine guided occlusion. What is unilateral balanced occlusion? Characteristics of unilateral balanced occlusion are there is exclusive contact on all posterior teeth on the working side during lateral movement. This distributes the occlusal load. It eliminates any tooth contact on the non-working side. In protrusive movement, no posterior tooth are in contact. Prevents excessive wear of functional cusp. Mutually protected occlusion, otherwise called as organic occlusion. Anterior teeth protect the posterior teeth in all exclusive movements, and posterior teeth protect the anterior teeth in maximal intercuspal position. Frictional wear of teeth is also reduced. Only anterior teeth in contact in lateral and protrusive excursions in harmony with the functional jaw movement. No posterior tooth are present. Posterior tooth contact are present. Stable posterior tooth contacts with vertically directed resultant forces in maximal intercuspal position. There is only light or no contact in anterior teeth. The lack of contact is termed disocclusion. Centricalization coincides with maximal intercuspation. Periodontally, sound anterior teeth are required for this type of occlusion. Advantages: patient tolerance is good, ease of construction. Disadvantage: periodontally weak anterior teeth, missing canines, class 2 and class 3 situation, crossbite situation. Canine guided or canine protected occlusion, a form of mutually protected articulation in which the vertical and horizontal overlap of the canine teeth disengage the posterior teeth in the exclusive moments of the mandible. That means in the lateral rosy movement of the mandible, only canine, maxillary, and mandibular canine tooth are in contact. All other posterior and anterior tooth are in disocclusion. What are the characteristics of ideal occlusion? Mutually protective occlusion forms the basis of ideal occlusion in natural condition. Stable posterior contact with the vertical resultant forces. Maximum intercuspal position coincides with the centricalization along with the freedom in center. No posterior contact in eccentric mandibular movements. Contact of anterior teeth in harmony with the functional jaw movement. Occlusion should be in angles clasped. Occlusion can only be judged from reaction it produces in tissues of the system in which it coexists. This reaction varies infinitely between individuals and may also vary within an individual with the time. Hence, some patients are capable of tolerating gross malocclusions without obvious discomfort, while others are unable to tolerate even minor occlusal deficiencies. Importance of ideal occlusion. Use it as a benchmark for assessment of pre-treatment record as an examination. been called as a diagnostic cast. Correcting of TMD and occlusion differences before commencing restorative procedures. For final prosthodontic rehabilitation, to accomplish this a confirmative approach when patient's retreatment occlusion is retained for prosthodontic rehabilitation, or a reorganized approach is utilized. Coming to occlusal interferences, what is centric interference? Mandible is closed in centriculation until initial tooth contact occurs. If increasing the closing force deflects the mandible, premature contact or interferences exist. This leads to deflection of the mandible, which can be in a posterior, anterior, or lateral direction. Interference occurs between mesial inclines of maxillary posterior teeth and distal inclines of mandibular posterior teeth. Working interferences occurs when there is contact between maxillary and mandibular posterior teeth on the working side, and this causes anterior teeth to disocclude. Interferences occurs on the maxillary lingual facing cusp inclines, the mandibular buccal facing cusp inclines. Non-working interferences. Non-working interferences is an occlusal contact between maxillary and mandibular teeth on the non-working side or balancing side when mandible moves in a lateral excursion. Interferences occurs on the maxillary buccal facing cusp inclines and mandibular lingual facing cusp inclines. It is destructive in nature because of non-axial nature of forces causing leverage of mandible. Protrusive interference occurs when distal facing inclines of maxillary posterior teeth contracts the mesial facing inclines of the mandibular posterior teeth during a protrusive movement. These are destruction forces due to closeness of teeth to the muscles, non-axial nature of forces, and inability of the patient to incise food. Interferences may lead to pathologic occlusion and should be assessed and corrected if needed, with the aid of mounted diagnostic casts before prosthetic rehabilitation is commenced. Pathogenic occlusion, an occlusal relationship capable of producing pathologic changes in the stomatognathic system, is called pathogenic occlusion. Signs and symptoms: teeth mobility is present, open contacts, abnormal wear like fracture, chipping of incisal edges, occlusal wear facets will be present. Periodontium, chronic periodontal disease will be present. Widened periodontal ligament space radiographically seen. Tooth movement and compromised crown to root ratio. Musculature, chronic muscle fatigue leading to muscle spasm and pain. Restricted mouth opening or trismus. Myositis. TMJ, pain, clicking or popping of the TMJ. Treatment. Short-term treatment. It is accomplished with occlusal splints or devices. They are used only for short period and provide the following benefits. So to deprogram the occlusion such that future restorations and regulation is easily accomplished. Act as a diagnostic tool in determining if a proposed change in occlusal scheme will be tolerated by the patient. They have also been beneficial in relieving myofascial pain. Definitive treatment. Definitive treatment may be comprising the following individually or in combination. Orthodontic treatment to correct malalignment, elimination of deflective occlusal contacts through selective grinding of intervening inclines, replacement of missing teeth to produce a more favorable distribution of force. This is attained by either occlusal equalization procedures or appliances like occlusal splints. Coming to conclusion, occlusion of fixed partial denture with the antagonist should be achieved favorably in order to fulfill the requirements of mastication, aesthetics, speech, support for orofacial structures, and prevention of temporomandibular joint dysfunctions. Thank you.